A very good morning to all. First of all, I would like to thank Professor Nazi Yusuf sir and the Egyptian Cardiodiabetes Association for giving me an opportunity to talk this in front of you. I'll be briefly discussing about female sexual dysfunction in diabetes. I'll be discussing under the following headings. In a study of women's health, more than 75% of women reported sex to be moderately to extremely important. The stages of normal sexual response cycle include desire, arousal, orgasm, followed by resolution. And these are the various models for the stages of sexual response cycle. Various hormones like estrogen, oxytocin, progesterone, and testosterone has got positive impact on various sexual function, whereas prolactin has got negative impact. Similarly, various neurotransmitters like dopamine, nitric oxide, norepinephrine, and vasoactive intestinal peptide has got positive impact on various sexual functions. Coming to female sexual dysfunction. Female sexual dysfunction is defined as the various ways in which a woman is unable to participate in a sexual relationship as she would wish. The clinical definition for female sexual dysfunction is that the persistent or recurring decrease in sexual desire or arousal, difficulty or inability to achieve orgasm, and or the feeling of pain during sexual intercourse constitute female sexual dysfunction. So it's a complex set of conditions associated with multiple risk factors like biological, medical, psychological, and social factors. If the desire and arousal is affected, it is called female sexual interest arousal disorder. If orgasm is affected, it is called female orgasmic disorder. And if there is pain, it is called genitopelvic pain penetration disorder. If you compare the DSM-4 and DSM-5, female hypoactive desire disorder and female arousal disorders are grouped into a single entity in DSM-5 as female sexual interest bar arousal disorder. And dyspareunia and vaginismus is also grouped into a single entity called genitopelvic pain penetration disorder. And female orgasmic disorder is adapted as C. Diabetes mellitus, the global prevalence is increasing and it is associated with both acute and chronic complications. The global prevalence of sexual dysfunction in women with diabetes varies from 20 to 80%. In a North Indian study, it was found that the desire disorder was around 45%, arousal disorder 62%, orgasmic disorder 84%, and pain disorder 20%. These are various studies regarding female sexual dysfunction in diabetes, and these are all various statistical data from similar studies. Coming to the pathophysiology, in people with diabetes, there is hyperglycemia, which can cause genital infection and sexual pain or discomfort. Similarly, hyperglycemia can cause dehydration and vaginal dryness, leading to sexual pain and discomfort. Similarly, hypoglycemia can lead to irritability and fatigue, leading to decreased desire. Vascular complication lead to reduced blood supply, vaginal dryness, reduced arousal, and female sexual dysfunction. Neurological problems like neuropathy and stroke leads to various female sexual dysfunction. Various comorbidities like hypertension, dyslipidemia, obesity, depression, psychological distress, hormonal issues like reduced estrogen and reduced androgen, all these can lead to female sexual dysfunction. Coming to the clinical features, female sexual dysfunction can present in varying ways: decrease or loss of desire, inadequate vaginal lubrication, inability to achieve orgasm, inability to relax the vaginal muscles, pain during intercourse. All these are the various presentations of female sexual dysfunction. So a proper history and thorough physical examination, including pelvic examination and essential investigation, will help in proper diagnosis of female sexual dysfunction. So, as in any other branch of medicine, proper history is the most important factor for reaching a correct diagnosis. So, the history includes socio-demographic factors, history of sexual problems, psychosocial and psychiatric history, medication history, contraceptive history, menstrual history, sexual history, and attitude towards the sexual issue. The partner can also be an important source of information in patients with sexual dysfunction. We have to differentiate, is it lifelong or acquired? Is it global or situational? And can the patient attribute a certain event to the onset of complaint? Various medication like anticonvulsants, hormonal medications, psychotropic agents, cardiovascular drugs, antihypertensive agents, all these can lead to various sexual dysfunctions. There are a lot of validated questionnaires to assess the female sexual function, like Female Sexual Function Index, Brief Index of Sexual Functioning for Women, etc. So Female Sexual Function Index, it contains 19 questions, and each question denotes various domains, like question number 1 and 2 for the domain and desire. For arousal, question 3 to 6. Similarly, lubrication, orgasm, satisfaction, and pain is also included in various questions. The model for addressing sexual health issues with the patient. There are different models. The most commonly followed models include Plicit model and Allow models. In Plicit model, it stands for permission, limited information, specific suggestions, and intensive therapy. Whereas in Allow model, it stands for ask, legitimize, limitations, open up, and work together. So a complete physical examination, including a thorough genitopelvic examination. In the physical examination, if there is features of endometriosis, we know that it can cause deep dyspareunia. If there is vaginal discharge indicating infection, it can again cause dyspareunia. Similarly, if there is galactorrhea, which indicate prolactinoma, again can cause decreased desire. Coming to the differential diagnosis, in female sexual interest or arousal disorder, we have to rule out relationship issues, depression, medication effect, thyroid disorders, hormone deficiency, vascular disease, etc. Similarly, in female orgasmic dysfunction, lack of education, lack of stimulation, arousal disorders, lack of desire, relationship issues, all need to be ruled out. In people with genitopelvic pain penetration disorders, vulvovaginal atrophy, endometriosis, gastrointestinal etiologies like irritable bowel syndrome, genitourinary causes, fibromyalgia, vulvodynia, vaginismus, uterine leiomyoma, pelvic inflammatory disease, diabetic neuropathy, all these have to be ruled out. And we have to differentiate superficial vulvar pain from deep dyspareunia, and these are the various causes. And provoked vestibulodynia is an inflammatory or immune response to an increased number of nerve fibers resulting in hyperesthesia. Coming to the investigation, the usual investigation include complete blood count, TSH, prolactin, adrenal precursors, sex steroids, cholesterol panel, liver function test, and a pelvic or transvaginal ultrasonography. Advanced sexual health assessment tools include vulvoscopy, vaginal photoplethysmography, functional MRI, biothesiometry, periometry. Coming to the diagnostic criteria, female sexual dysfunction diagnosis, the symptoms have persisted for a minimum duration of 6 months. Symptoms cause clinically significant distress, and the sexual dysfunction is not better explained by a non-sexual mental disorder or as a consequence of severe relationship distress or other significant stressors, and is not attributable to the effect of a substance or medication or another medical condition. So in female sexual interest or arousal disorder, there is absent or reduced interest in sexual activity and reduced or absent erotic thoughts or fantasies, initiation of sexual activity, excitement or pleasure, and reduced or absent interest or arousal, and genital or non-genital sensations during sexual activity. Whereas in female orgasmic disorder, there is marked delay or marked infrequency or absence of orgasm or markedly reduced intensity of orgasmic sensation. Genitopelvic pain or penetration disorder, there is difficulty in vaginal penetration, marked vulvovaginal or pelvic pain, marked fear or anxiety, marked tensing or tightening of pelvic floor muscles. Coming to the treatment of FSD is a challenge because of the lack of a single causative factor, limited proven treatment option, physicians' unfamiliarity with available treatment, overlap of different types of dysfunction, limited availability of treatment, limited expertise in the treatment of female sexual dysfunction. The basic principles are patient-centered approach, couple-centered approach, therapeutic patient education, and shared decision making. In people with diabetes, treatment of diabetes and control of risk factors are important. Various psychosocial treatment options include psychoeducation, sex therapy, mindfulness training, cognitive behavior therapy, communication training, sensate focus exercise, sexual fantasy training, and directed masturbation. For hypoactive sexual desire disorder, the treatment includes education, treatment of underlying cause, stress management, testosterone, topical and systemic estrogens, phosphodiesterase inhibitors, bupropion, DHEA supplementation, and flibanserin. Sexual arousal disorder treatment include education, eros clitoral therapy device, phosphodiesterase inhibitors, and lubrications. Orgasmic disorder treatment options include directed masturbation, penetrative or non-penetrative, vibrating sex aid, psychosexual support, clitoral therapy device, cognitive behavioral therapy, phosphodiesterase inhibitors, bupropion, and yohimbine. In patients with sexual pain disorders, education regarding the need for adequate stimulation prior to penetration, addressing the underlying cause, like if it is due to vaginal dryness, use of lubricants, physiotherapy, psychotherapy, cognitive behavioral therapy, systemic desensitization, all are important. In postmenopausal vulvovaginal atrophy, vaginal lubricants, systemic hormonal therapy, vaginal estrogen therapy, and ospemifene for dyspareunia are all used in the treatment. Omega-3 fatty acid improve the general well-being, improve the libido, and prevent menstrual syndromes like dysmenorrhea and postmenopausal hot flushes. Testosterone transdermal patches are used for hypoactive sexual desire disorder in postmenopausal women. DHEA improve the frequency of sexual thoughts, sexual interest, and sexual satisfaction. The various vaginal estrogen therapy include cream, ring, and vaginal tablets. Phosphodiesterase 5 inhibitor increase the blood flow to the genital organ, thereby increasing the sexual arousal and lubrication. And vaginal lubricants reduce the dryness and improve dyspareunia. The various lubricants are water-based, silicone-based, or oil-based. Flibanserin is a drug approved for generalized acquired hypoactive sexual desire disorder in premenopausal women. It's discontinued after 8 weeks if there is no improvement. Common side effects include dry mouth, hypotension, syncope, contraindication like alcohol use, hepatic impairment, etc. Tibolone reduce hot flushes, increase the bone mineral density, and improve the desire, It has got positive effect on vaginal dryness. Yohimbine hydrochloride is a selective, competitive alpha-2 adrenergic receptor blocker that has got central activity. Bremelanotide is a melanocortin receptor agonist used in the treatment of hypoactive sexual desire disorder. Bupropion is effective in reversing selective serotonin reuptake inhibitor-induced sexual dysfunction in premenopausal women. Alprastodil is a potent vasodilator. It increases the vaginal blood flow and it leads to increased sexual arousal. Ospemifene is a non-selective estrogen receptor modulator useful in the treatment of vulvovaginal atrophy and dyspareunia in postmenopausal women because of the estrogen agonistic effect of ospemifene in vaginal epithelial tissue. The common side effects include hot flushes, vaginal discharge, vascular disorders, and risk for various and problems like endometrial hyperplasia and endometrial cancers. Contraindications include undiagnosed abnormal genital bleeding, known or suspected estrogen-dependent neoplasia, history of or active DVT or pulmonary embolism. The Eros stimulator is the only device currently approved for or the treatment of female sexual dysfunction. It's a battery-operated device with suction cup. It fits around the clitoris and facilitates engagement. So to conclude, sexual dysfunction is common among women with diabetes. Treatment of FSD requires a multidisciplinary approach. Optimal glycemic control is the key component in the management of FSD in diabetes. This is our article where we described challenges in the diagnosis of vaginismus and we proposed a diagnostic criteria for vaginismus. Thank you for the patient listening.